Thank you for calling Tampa General Hospital. We are unable to identify.
Gaetane, are we about ready to go?
I am indeed.
Well, it's my pleasure to introduce Dr. Gaetane Michaud, our Director of Pulmonary and Critical Care Medicine. She has an exciting presentation today on her journey on organizing a program from the ground up to deliver critical care high quality to patients. I think it's a very interesting area and something that's easily transportable to all areas of internal medicine and beyond. We're excited to hear this. Gaetane, go ahead and go to it.
Okay, just give me 1 second. I'm just going to open my slides for you guys. All right, well, I'd like to thank everybody for participating today. I want to talk to you about a project that's been near and dear to my heart since I first got to USF back in 2020. Not long after arriving in November of 2020, we embarked on a project to restructure the cardiothoracic intensive care unit in order to actually close the unit, or to what is more politically savvily called rendering it intensivist led. And so we're going to talk to you. We're going to talk today about how what our process was, kind of, and the steps leading to that. We're going to review the timeline and individual steps involved in the transition of the CTICU and moving it from an open concept to an intensivist-led model. We're going to talk about the redesign of the multidisciplinary care team in the CTICU. We're going to talk about the roles and responsibilities and how we sort of have negotiated that to ensure that it is indeed intensivist-led. We're going to talk about the role of each member of the team, and we're going to talk about a lot more. So the very first step in this process was to actually develop a project charter. This began even before the first time that we met as a team, as a larger team. Basically, what we did is we gleaned support both from Tampa General Hospital as well as from the USF leadership teams. And the reason we needed that was to actually engage the entire team in the process to achieve our common goals of closing the unit. We also engaged the process improvement team from Tampa General. We worked directly with Sarah Correa, Audra Regan, and Maggie Pogenpol, and I can be honest with you and tell you very clearly that we would not be where we are today without them in this process. In this slide, I'd just like to highlight the problem statement. The reason that we actually took this on was that we clearly identified that there was variations in practice in this unit. And that was due to differences in provider comfort levels, experiences, and prior knowledge. We also identified that there were limitations in team member resources, i.e., we didn't have dedicated advanced providers. We did not have a dedicated CTICU team of intensivists. We actually rotated, all the intensivists actually rotated through the service. We had a limited nursing availability as well. We had unclear leadership structure. So although we had a medical director in that unit, there were also advanced heart failure involved. There were the surgeons, and people didn't know who was actually in charge. And the nurses were given orders from multiple different teams, and they had no idea who to listen to. There wasn't a clear governance structure. There were a lot of gaps in communication amongst the team members. There was a lack of roles and responsibilities that were clearly defined. And the other problem that we had, to be honest with you, is we had a declining staff, i.e. nurses were leaving, and the nurses and the physicians, as well as the APPs, were not engaged. So this was a really big thing. Now, this project took on an enormous scope. And the reason it took on an enormous scope is because it actually included the care from the time of admission and the decision to admit to the unit all the way through to discharge and transfer out of the ICU. So that's a very long scope of practice. And for many of these patients that are on ECMO or patients that are awaiting transplant, both heart and lung, these hospitalizations can be quite long. So this is a very long time frame. The next thing that we did is, even in advance of meeting with all of the stakeholders, we sat down and identified potential opportunities. We definitely thought that we could actually report out and create a leadership structure. We thought that for sure that we could improve the resources and coverage schedules. We could develop education for the team with an emphasis on the patient population for that specific unit. We could provide physician oversight for the unit. We could improve communication, standardize patient flow, standardize roles and responsibilities of each of the staff as well as the physicians, and actually standardize the admission and discharge criteria for that unit. I also identify some significant barriers. I mean, the unit had been functioning in a certain way, and there was a long history, a lot of water under the bridge. So we did feel that we were likely to meet some resistance from the physicians, probably also from the unit staff. I mean, it's one thing to want change, it's another thing to accept change. And we had tried to alter that unit in the past. We tried to close the unit 2 years prior, but those changes were not sustainable. So we wanted something that was going to be sustainable. And we still had limitation of resources. And so we really needed to be aware of those limitations and kind of work within those limitations. We also set out some very kind of broad-based metrics that we may want to actually consider, which, we basically said at that point, we'll see what the team has to say as we get together. But we definitely thought that patient experience, we thought culture of safety or some sort of equivalent, and some staff engagement were definitely important because we had already identified the lack of engagement of the staff. The next thing that we did is we sort of set out a timeline and a few things that were really important. So communication was really a very big thing. Now, I will tell you, the way we set out the communication was that we would send out reports to the executive team, and I'll talk to you about the team in a few minutes, but we would send out executive minutes for meetings to the executive team, with the expectation that because there was representation from all of the stakeholders, that information would trickle down to the individuals on the front line. That said, I think, to do this again, that is definitely one area that I would actually do differently. And I think that providing sort of at least quarterly updates to the people that are boots on the ground, the people that are actually in the process of the implementation, not relying on their direct supervisors, I think I would probably go that route because that was probably something that I could do very much differently. Next thing that we did is we set up a meeting of the stakeholders, and we actually did a process map, which actually showed us where we were in our current state. We actually created what is called an ideal state or a future state process map. And then what we did is we compared the two. We said, this is where we are. This is what the unit looks like. This is how it functions. And said, ideally, these are the, pie in the sky. This is where we'd like to see ourselves. And so what we did is, and this was all during our first kickoff meeting, which was actually I believe it was the 2nd of November. Yeah, it was the 2nd of November of 2020. We sat there and we actually created opportunities that we identified to go from our current state to our ideal state. And we actually put those together. And then what we did is we set up a prioritization meeting where we could actually go through those opportunities and prioritize them. And just to give you some idea, this is the representation. So we had the executive team, which included the leadership, both from the university as well as from the hospital. We also had a physician champion, which was me. So I was the one pushing this envelope. And then we had representation from transplant, from cardiac surgery, as well as cardiovascular surgery. Cardiac surgery and cardiology. We also had a project facilitator team, and that included the project manager as well as 2 project facilitators. I will tell you that Audra Regan actually became our project manager when Dr. Oliver stole Maggie from us. And then we had a project team. Now, keep in mind, one of the biggest things that was occurring during this time frame is we were doing this massive project in a time of COVID, where we had a lot of restrictions on how we could actually kind of work through this process. Normally, this is an in-person type process. However, that said, for us, we did a lot of this virtually because of the confines of COVID. We had a max capacity of 10 people in a room at any one time. So the people that are highlighted in yellow on this list are all people that were actually involved in person. We tried to actually have a cross section of representation from APPs, nurses, and all of the various consultants that actually worked within that unit. We had that in person, and then all of the people who were not highlighted were participants that were actually virtual. But it was virtual real time. To set the stage, what we did is we looked at some of the team member engagement metrics from the prior year's survey. And what you can see here, and I think some of the things that are really important are that we were very under-resourced, or at least our team felt that we were very under-resourced with respect to nurses and physicians and APPs. Communication between the team members was challenging and often deemed ineffective. There was not necessarily a culture of safety within the unit with a focus on and no focus on improvement necessarily. And overall, the team just felt very stressed. So being that this is a cardiothoracic intensive care unit, we actually report out data to the Society for Thoracic Surgery database. And that is sort of our benchmark. So what we did is we pulled some data from this. This is just a representation of 2 patient populations that we looked at, although we did look at the cross section of data from including transplant, as well as our mechanical support patients. But this data presented is our cabbage patients, as well as our aortic valve replacement data. As you can see here, we were not performing all that well compared to other centers that looked like us, as well as centers as well as all centers in the STS. If you look at the pink boxes, they represent where we are less effective, have worse outcomes than both centers that look like us, as well as all centers in the STS database. The green boxes are those where we do better. So overall, you know, with respect to time on mechanical ventilation and reintubation rates, we were not doing as well as other centers from across the country. And in fact, actually, we were doing twice as poorly as many of these centers. And then if you also look at our readmission rates, so not only are we reintubating people more often, you know, we are actually, and we're mechanically ventilating them longer, they're bouncing back to the unit much more frequently, 2 to 3 times what they were in other centers. So we had a lot of room to go and to improve. This is just the same data presented in a slightly different way. So this is our data by month over the same time frame. So the 2019-2020 data time frame. And so what you can see here is if you look at the yellow lines on the bottom, the yellow lines on the bottom are actually the other STS data sets. And so you can see here that we have these strange peaks that happen a long time frame. Even our baseline, however, is actually not very good. The only times that we are below the STS databases is when we aren't actually doing patients. We weren't actually doing surgeries. So that's a bit disturbing. You know, we've looked at this data, we're trying to understand what these peaks actually mean or why they exist. Not entirely certain. You know, there is some suggestion that it could be transitions of surgeons, transition of intensivists. It's not quite clear. But overall, we were doing more poorly than outcomes-wise than other centers across the country. When we looked at the CTICU timeframe and we followed patients throughout, we found 5 discrete time events that occurred. So the patients were admitted to the unit. They were either admitted from the emergency department, they were direct admitted, or they came from the operating room. We had this time frame around multidisciplinary rounds where we had all kinds of attendees. We had a leader, we had roles of the attendees, and we had discussion points. We had the handoffs to and from the operating room, and also to and from like providers across the gamut of their care. So whether that was actually also from the emergency department or from an outside unit. And so we had issues with respect to communication and transport, OR communication, and patient preparation for a transition. We also had time of decompensation. So patients in those units are really, really sick, and they tend to decompensate over time. And then there was the discharge time frame. And so you'll see that a lot of this project from that point forward was kind of broken down a little bit according to this. So the next thing that we did is we took all of those opportunities that were discussed or that were derived from our meeting on 11/2/2020. And what we did is we actually put them together. We sent out those opportunities to the participants and asked them to rank order them. And so we sent those out and we got their feedback. And then what we did is we created a prioritization matrix, and this is it. And what the prioritization matrix does is it actually breaks out these opportunities based on, whether or not they are quick wins, meaning that they have a lot of impact and they don't take a lot to implement. They are big bets where there's a lot of impact, but it is going to be challenging to implement. They are incremental benefits, so not a lot of impact, but not a lot of challenge to implement. And then, that lower right quadrant, which is money pits, meaning that they're really impractical. They take a lot to implement, and they don't have a lot of impact. So anything that falls into that quadrant 4, they're really impractical and they're not worth your time and effort. Anything that's in quadrant 1, which is that green box, those are things that you should consider top priorities. And then, then the other for consideration are either incremental changes or those big bets. Now, when we put our top 11, we had, I think it was like over 25 priorities that came out. We put them into 11 buckets. Closing the CTICU, changing the APP structure. Historically, the APPs in the CTICU were surgical APPs, and they were not involved in the day-to-day care outside of surgery, outside of the surgical issues of the CTICU patients. So therefore, we didn't have on the intensivist side, we didn't have a lot of support other than the fellow in the unit. There was no admission, there was admission criteria, admission process, patient management protocols, multidisciplinary redesign, pre and post-op handoff, interim escalations, and I'll explain to you what that means in a moment. And then discharge criteria and pathways of care, as well as team education and training. And as you can see, it's interesting because the way it fell out is that most things were deemed quick wins, and only 2 things were actually big bets. Now, what's interesting are the big bets were closing the ICU, so it was actually the goal of the entire project, and changing the APP structure. And so they were deemed our 2 big bets, but they were the 2 things that were going to actually limit our ability to be successful. So we had to take on those big bets. The next thing that we did is we created a timeline. So we built out work groups to work around each one of those opportunities from the people that participated in the performance improvement project. We made sure that each work group had appropriate representation. So, I mean, if it was a surgical issue and, it was a respiratory therapist, they may or may not have been involved because it plus or minus touched on what they were doing. So we made sure that there was adequate representation and it spanned the spectrum of the multidisciplinary team involved in that specific patient population. Then what we did is we mapped out the things, the time frame. So, one of our very first two things that we did is actually sought out to create a infrastructure of leadership for that unit and to take on, and that's the CTICU operations oversight. And then we also wanted to actually restructure the APPs because that was going to take us a long way to actually get adequate resources into that unit to be able to provide a top level of care. So when we talk about the CTICU APPs, like I said, they had historically been CT surgical APPs, and they really didn't have a lot of interest in working with the intensive care team other than to act as consultants. So we actually negotiated with CT surgery. That unit had been assigned 18 APPs and had funding for 18 APPs that said they were all on the surgical side. So what we did is we negotiated with Dr. Lasansky, and 10 of those APPs were reassigned to CTICU APPs. So, and then we actually went to the existing team and asked them who was actually interested in moving from the surgical side to ICU care. Of that, there was only actually one person who came across, and the rest of the people preferred to stay on the surgical side, which is fine because that left us 9 positions to fill. And so what we've been doing since that time is actually filling those 9 existing spots. And at this point in time, and we created an onboarding schedule for them, which was a few months of training, both outside of the CTICU to learn some skills that were necessary. So some time in the operating room to understand the surgeries better, some time on the wards to see the patients post-operatively, et cetera, and then some skills-based time. So in the operating room to learn how to intubate and to do lines, et cetera. And then a lot of time in the CTICU being sort of shadowing initially, and then actually being assigned to a senior person. So we've actually gotten a nice mix of APPs that are very experienced CTICU APPs. So they actually had multiple years. I think the person that has the most years is about 15 years of CTICU experience, experience with the devices and the transplant patients. We now have 9 APPs hired. We now provide 24/7 coverage of APP coverage that is in-house, and the structure is 3 APPs by day. When we have a lot of rounding, we have a lot of medical issues, we try to address all the skills-based things, such as if there's a procedure that needs to be done, we try to get it done during the day and provide a plan for the day to keep people progressing through the continuum of care. And then we have 1 APP to assist the overnight attending and the overnight fellow. What we realized is because there wasn't a leadership structure, there had been this issue with nurses not really knowing when these complex patients decompensated who they were supposed to call. And so they spent a lot of time chasing physicians and chasing providers to try and get the care that they needed for their patients. And in that, they were afraid that they were going to call the wrong person, so they called 5 people, and meanwhile you had an unstable patient. So what we did is we looked at these sort of complex patients that had a tendency to de-escalate, to escalate quickly, and that included the mechanical support patients, the ECMO patients. And so what we did is, and then overall CTICU patients. So what we did is we created clinical escalation pathways for these patients. So, and we created these flow diagrams that allowed and process maps that allowed the nurses to follow a set stepwise progression through that escalation. And then, one of the biggest things was that we didn't have good communication in that unit. So we also, around that, created a framework for communication. We utilized a tool called SBAR, which is Situation, Background, Assessment, and Recommendation. And it basically walks them through how to communicate effectively, particularly in a time frame where a patient is decompensating. And then, there was a lot of concern that, well, what happens if I'm not being listened to? What happens if they're not doing as I ask? So what we did is we taught them also a tool called ARC, and this comes from HRO principles, which is how it's a way of asking for an escalation. So addressing your concern and pushing it up the pile if necessary. So the A stands for ask a question. So the first R is make a request. So you're going to make a request for change. The C is voice your concern, saying, I'm not really getting what I want. This is what I want. And then the next thing is, how do you go up the chain of command? This is actually just a blown up version of one of the ECMO patient escalation pathways. And as you can see, it actually contains very, very easy to understand instructions for the nurses. So I have a patient who's hypotensive. Here are the 4 things that I need to do first. I need to call the intensivist, use SBAR to call the intensivist, and then the intensivist then calls the cardiologist or the CT surgeon. So it makes it very clear. It keeps the nurses out of the line of fire for not doing the right thing. But it also keeps the intensivist, and in an intensivist-led model, you want the intensivist to be the one actually leading the care, and it keeps this kept the intensivist in the front seat. Oops, sorry, went the wrong way. And then this is just an example. So for each escalation, we actually gave them very specific frameworks and very specific ARC tools, and it related to the type of patient that was addressed in the escalation process. So this is what they received. This was all part of their education. And we had multiple sessions with the nurses where the physicians that worked on this actually walked through this escalation process with the nurses and addressed their questions. Then what we worked on was the multidisciplinary rounds, because although we were all meeting as a team, there was actually not a designated structure for it. We thought we were doing multidisciplinary rounds, but then what we realized is we kind of weren't. We were kind of missing the ball on a lot of things. So what we did is we created a responsibilities matrix that we gained consensus on amongst the providers. And then what we did is we decided on what metrics we were going to collect to see if we were being successful. We created a multidisciplinary EPIC note template, and then we started piloting the framework. This is the roles and responsibilities matrix. Essentially, what this does is it takes the individual functions that occur within the unit and within the multidisciplinary rounds. And then what we did is we sat down and said, okay, well, if this is an intensivist-led model, then the critical care attending should be accountable to ensure that all of these functions are performed each day. And so they are the accountable party these functions. Then what we did is we looked at the consulting physicians, so the CT surgeons, the advanced heart failure physicians, the lung transplant, the cardiac transplant, and we actually we consulted them in all of these decisions, in all of these processes that we were going to evaluate. And then there was the CTICU fellow and the CTICU APP. They were actually the ones that were responsible for implementing each one of these functions on a day-to-day basis. There were some things that were implemented by the CTICU nurse or the respiratory therapist or the pharmacist, depending on what they actually were. But for the most part, they were actually just informed of the functions. So as you can see here, this is actually a photo of what our multidisciplinary rounds now look like. A few things that were really important were to render it a distraction-free environment. When I first got there and started doing observations in that unit, I mean, the radiology machines would go through, and there were doctors that were actually coming into the unit and discussing other patients loudly and disrupting the flow of rounds. And then there was the additional factor, which was actually kind of crazy, which was that all of the computers on wheels, they were all oriented the wrong way, so no one could see the images, and they were acting like they were sound barriers, so people couldn't hear one another. And the nurse was in the back of the room and oftentimes did not actually even participate in rounds. So what we created was a roles-based multidisciplinary round, and we scripted that out. So each member of the multidisciplinary team has their specific role within that, and it was scripted out what they had to include in their individual proportions of this. And then the final thing that occurred with these multidisciplinary rounds is there was actually an educational component that came through. So that with each patient, each day, there was at least 1 point of education that was discussed per patient. And then the second thing is that during each round on each day, there was 1 to 2 patients that were very specifically selected because they had something of interest. And what happened was those educational opportunities would last 5 to 10 minutes, and they would be a bit in depth of a discussion. And so we're trying to bring education to the bedside, bring everybody up to the same level. Now, this is particularly important in our environment currently, where we have a lot of traveler nurses, a lot of junior nurses, and these patients our complexity of care is through the roof. So this is actually a very important part of our rounds on a daily basis. The next thing that we did is we actually created patient management guidelines. So we selected a few areas where there was marked variability in practice. And those were identified, the three things that were identified were VV ECMO, VA ECMO, and vent management. And then what we did is we created standardized protocols for those 3 things to be able to try and minimize that variation in practice. And those were also areas where we knew that we were below targeted metrics. So they had a high ability to, if we minimized variation, we standardized care and we functioned within standards of care. Then what would happen, our hope was that we would come up and actually improve our outcomes in those areas, which we were being benchmarked. So happily, on July the 12th, in the middle of a pandemic, we actually succeeded at becoming an intensivist-led unit. We actually tied the knot. And so I hope you guys think this is funny, because this was actually a cake that I brought in and I thought I was hysterical, and the lady who made the cake did not understand it at all. So the play on words is that we actually tied the knot. So we tied the door shut to not allow anyone else in that did not belong in that unit. So we, at that point, had hired a dedicated, well-educated staff of intensivists. So we had dedicated people and people that were not as comfortable in that unit, but were really good intensivists, but didn't really like that population. We really focused on intensivists and bringing in that unit and having them work mainly there if they had a particular interest in that population. The intensivist was the leader, and they collaborated with all the specialists. They had a lot of, we evolved into having many physician-to-physician conversations. We talked a lot about the patient care, surgeons, intensivists, and cardiologists. So true multidisciplinary care, taking the best of all of our providers. That said, there still remained a lot of variation in practice, and it was really important in it that in certain subpopulations, and we broke the patients in the CTICU out into subpopulations: the routine cardiac post-surgical patients, the heart transplant patients, the lung transplant patients, the mechanical support patients, the respiratory failure patients, and the massive or submassive PE population. And basically what we did is we are still in the process of creating care pathways for those patients. And that is from the time of admission into that unit to the time of discharge taking each and every aspect of their care and creating a template of this is the standard by which we will function for this specific patient population. This is a lot of work. It is all evidence-based, and we have working groups working on this currently. This is an example of the post-cardiac cardiac transplant patient, and this is the most recent one that is being implemented currently. Next was actually our handoffs. So we worked on developing a template for handoffs, and those handoffs could be from coming to and from the OR. That's the most common one, and ensuring that all of the data that we need to be able to actually move forward with the care of those patients and optimally manage them is reported out at the time of that handoff, so we weren't having gaps. And so this has been working really nicely. And then finally, this is our sort of status report as of 2 days ago. So as you can see, the APP structure and transition, we're on track. We hired the last APP, hopefully this week. So in the next 2 months, we expect that transition will be complete. The transition to intensivist led, obviously, since July of 12th, 2021, we've been an intensivist led unit. We still have some growing pains and we still have lots of things to learn and lots of new ideas to implement, and we are open to those. We have completely implemented the clinical escalation pathway, have done so for over a year now. We have the multidisciplinary redesign, that has been in effect since April of last year, and is working well. We are still making tweaks, things like immunosuppression, for example, where we're still having to make some tweaks. The pathways and protocols, those are ongoing, but we are on track, and we're, like I said, breaking it down. We did get a little bit of a delay with that, and only because we had broken it out several different ways. And finally, it ended up being that we were being too much of splitters and not enough lumpers. So we actually had initially thought we were going to do care pathways for every single cardiac surgical patient subtype possible. And then we realized that the burden of work for something that was not that discretely different, a routine CABG versus aortic valve, the routine care for a standard, easy to run patient is not different. So therefore, we actually redesigned that to be lumped into buckets, like I discussed before. The transitions of care, those documents are all very process oriented. They've been implemented since January of 2022, and that's complete. They are completely implemented. And then we got delays in the education and training. We do the education portion for the multidisciplinary rounds, but what we are envisioning is actually a team-based skills education platform through CAMELS. And so what we are going to do is we want all of our physicians, APPs, nurses, and other team members aware of how we would actually function as a team in an escalation of care. And so we do want to get all of our providers ECMO trained, and that's a really big thing. We also want to get them very familiar and very comfortable with the mechanical support devices. And so what we are creating is almost like an ECMO course, our own like ECMO course plus. So it would be ECMO plus the device training. That would be didactic with some hands-on of manipulating the mechanical support devices, so that and learning to troubleshoot them, and then utilizing a final day. So do it a multi-day course and utilizing the final day as a skills-based educational opportunity. So we would do simulations with the entire team present, everybody functioning in their roles, which they do every day, and then having them troubleshoot complex escalations. And then in that setting, having our consultants and our higher level members of our team, people that are more experienced members of our team, providing feedback to the team as to what they might have done slightly differently, how they could have actually troubleshot things in a slightly different manner, to ensure that we are actually every single time functioning the same way and ensuring that we get rid of that variation in care. And that's where we are today. I'm happy to answer any questions you guys have.
Hi, Gaetane. This is Jose Harasso. I have a question. One of the things that I've seen since CTICU was made, intensivist led or closed for another word, is that it feels that unit is busier. It feels that we, in the past we may had 4 beds open here and there. Now it's more like, we're struggling for beds. I don't know if it's part of the process of having a better pathway to a patient, coming here. I don't know what it is, but it feels a lot busier. How do you foresee, in the future, how, as we grow, are we going to extend ourselves to different, maybe different units? For example, today we have 8 ECMOs. Are we planning on growing the staff, growing the number of beds? Any thoughts on that?
Yeah, that's a really good question, Jose. So, I think that just like all things, we are a victim of our own success. So we have done extremely well. We've been able to grow. Within this process, we have integrated new surgeons. So we have 2 new surgeons, and we're implementing a shock program. So I think you are correct. I think that the next step is going to be to find out where the stop gaps are, and certainly there's a lot going on behind the scenes to kind of expand this unit and to develop the shock program. I think that what I foresee in the future is that the CCU will be a second unit where these patients can actually function. And so what we would have, what we would see is that the higher level, higher intensity surgical patients would remain in the CTICU. Some of the devised patients that are a little less sick would be in the shock unit on 2D, but that would also necessitate it having 24/7 coverage and being intensivist led as well. So closure of that unit, and then taking the CCU and actually kind of downgrading that or having a step down unit for cardiovascular care. That said, this is going to require again, sort of a repeat performance of what we've already now done, which is we're going to need a dedicated staff. We're going to need APPs and physicians, and we're going to need protocols, et cetera. So I think that is coming. But I do think that you are correct that certainly the acuity of care is actually escalating. I think our outcomes, and in fact, I know that our outcomes are better. I've been tracking them. I have a meeting this afternoon where we are actually tracking our metrics. We are actually creating a dashboard to be able to monitor our metrics that we've been watching over the last year and a half. I know that outcomes have already started to improve. And definitely that we are waiting to see. I saw the preliminary data on the engagement survey, and it's actually better as well.
Thank you.
Dr. Anderson, did you have a question?
Can you hear me?
Yes.
I can hear you now.
So I put it in the chat. You've done an excellent job of accomplishing an impossible task of having cardiologists, intensivists, surgeons talk to each other. Do you have any other preliminary results? Because it looked, the first part of your talk looks like a pretty daunting task.
Yeah, so I know that our vent times have gone down. We've implemented a ventilatory strategy thanks to Dr. Juan, who is the person that created that. So we are now ventilating in all the similar fashion with the goal of time to extubation within 6 hours. That has definitely improved. Our reintubation rates have gone down. I don't have all the data in front of me, and I'm not at liberty of demonstrating that data quite yet. So because it's still early. And then so vent hours has gone down. Our time to extubation has gone down. So with our percentage going that are extubated within 6 hours and per protocol is actually much better. Our vent days are decreased. I know that our morbidity and mortality are actually going down as well.
Thank you.
And I spoke to the patient, the provider engagement survey as well.
Hey, Gaetane, this is Jose Harazo again. I think one thing that is not necessarily a question, but more of a suggestion that probably would be nice to see is, trying to creating a fast track pathway where we can, select certain patients and try to get them extubated, very quickly after they come out of the OR, and instead of, kind of wait until the next day or so I think that's something that we definitely need to discuss down the road.
Yes, and that's actually part of the care progression pathways, Jose. So fast tracking them to extubation is definitely on that. And I mean, we're still seeing some variation in our practice as intensivists. Some people are more rapid to extubate. I don't know if it's because they feel more comfortable with reintubation or not, or they're I don't know, more resistant to reintubation. I don't know. I mean, I think that you are correct. I think we have to make the decision to fast track certain patients, and there is a pathway to fast track that is being implemented into the care progression. So I realize that this is all related to the CTICU and a lot of things, but I really want to, the reason for selecting this topic is because we really did a full-scale restructuring. And probably the biggest thing that we actually did in this project was actually change the culture, which was huge. Because in a year, we were able to change the culture. When we first started out on this path, all we heard is that we were going to fail, and this was not, this was an impossible feat. And what we've seen is because of the work product that we created sustainability. And I'm really proud of what we have done as a team, because I think that what has actually happened is that these tools and all of this work product can be recycled and reutilized in other events that if we so choose to utilize them.
I think that was excellent. Thank you very much. And Dr. Michaud will be available for questions later. You can call her, email her. But what a wonderful success story. Thank you very much. Everyone have a good day. Goodbye.
Thanks everybody.
Thank you.